So the next half an hour, I will first present on MRD-guided management, explain you a bit why we are excited about it, but also why maybe me and my colleagues are still hesitant. And then Barbara will talk about novel agents, and then we have a discussion. And I have to apologize in front, but I have a taxi 10 minutes before 6, because otherwise I'm too late to the airport, and my family gets upset. So that's why I will step down a little bit earlier. So the whole last 2-3 days, actually, we had very extensive discussions, even this morning, led by Barbara Eichhorst, on MRD and should we do it in CLL and not. And I think it's already difficult for patients and their families to understand all the drugs that we give, but I think what I heard today so far is that indeed you did a very good job in that part, but this is even a more difficult part. So what are we actually measuring? Why are we so excited about it? And what is MRD? And in the first couple of slides, I would like to explain to you what it is, and please ask questions later or during the talk if anything is unclear, because I think it's going to be more and more relevant. And in the next part of my presentation, I hope to share with you how we can actually use MRD in CLL. And all those questions, I don't have the perfect answer, and I think nobody, but we are very actively exploring this in the field. So the whole idea about MRD is that with normal techniques, just looking to the microscope into the blood or in the bone marrow, you have a very limited scope, and you can detect maybe one leukemia, one wrong cell in 200 cells, but that's pretty much it. And we do know that there are much more leukemia cells in the human body, also in the blood, but you need different techniques to use that. And over the years, we have adapted new techniques in hematology, like flow cytometry, where we are already doing this better, but based on more colors that you can build in. I'll come back to that later. Or looking to specific genes, actually, you can actually get a much better idea of how many CLL cells are there, specifically when they are very low level. And we have a new thing to play with, which is called next generation sequencing. And it's a very strange name. It's already called next generation for, I think, years and years. So I'm not sure if you can still call it actually next generation, but it's how we do it, which actually means a semi-automated way of checking with a very, very sensitive method different genes of choice to see if you can detect those genes in a whole pool of cells or blood, which has a lot of normal genes as well. So the whole idea, I think most of you know Where Wally, which is very popular for children, right? You have these very difficult pictures and you have to find Wally, and that's actually pretty much what we try to do with MRD. So I know it's a little bit late, so I help you a bit. He's over there. So you don't need to look for that. But actually that's what you do with MRD. You're trying to find the easiest way to detect more and more, with more and more depthness, more and more sensitivity, the Wally in your normal blood. And one way to do that is by flow cytometry. So if you look to the right upper part, that is a normal B cell. A normal B cell, the reason you have B cells is to make antibodies. So you have a B cell receptor that recognizes antigen. It will adapt a little bit in the lymph nodes to have this perfect match. That's why vaccinations work. And then the B cell will make antibodies, actually exact copies of this B cell receptor to go out of the cell and then to attack a virus or a bacteria or whatever far away. And those normal B cells in different stages of their development, when they leave the marrow, when they are in the lymph nodes, when they're becoming a plasma cell, at every moment they have a specific type of markers, which are actually molecules on the surface of those cells. And what you can see in the top is a normal B cell at a certain differentiation point. And over the years, we have learned that there are specific markers that differentiate them a little bit. They're still very much, if you under the microscope, it's sometimes completely not possible to have a CLL cell different than a normal B cell, but with those markers like ROR1, CD200, CD5, which is normally on T cells, we think we have a pretty good way of showing what are the CLL cells and what are the normal cells. So that's the way to do it with flow cytometry. You actually measure the surface markers with different colors, and then you can detect whether or not there are still CLL cells around. Another way is do it molecular. So again, what I explained is that the reason you have B cells is that you make plasma cells, and those plasma cells make the B cell receptor that originally recognized an antigen, like COVID, into antibodies that actually can attack these viruses. And it's good to know that the whole idea about every cancer, but specifically also CLL, is the hypothetical idea is that everything started with one cell that had a mutation or had this hydrogenetic abnormality, and from that cell you get new cells and new cells and new cells, and therefore every cell that comes out of this mother cell should have the same B-cell receptor. And a B-cell receptor has specific genes, and those genes you can sequence, you can do PCR, so you can do this next generation sequencing, and therefore you can actually detect this specific clone of the original clone from the CLL in a pool of cells with a lot of different clones of normal B cells. And so that's exactly what you do, is you take cells from blood or marrow or wherever you want to look, but mostly it's blood and marrow, and then you will look exactly in the DNA sequence of the region that codes for this B-cell receptor, and then you can detect also with almost the same, maybe even better sensitivity than flow cytometry, whether or not you still have disease. So then the question is, okay, by the technique we can do it, and then what? Then what can you learn from this? And I showed you here a hypothetical model is where you give treatment and you stop treatment. So what you all discussed in the earlier sessions is what we call time-limited or fixed duration treatment. And what you can see here is that you have a lot of different ways for patients to respond to those treatments. So the red one is probably a patient that is resistant. So you see that there is a very little dump in their number of the leukocytes. Probably you don't need any expensive NGS or flow. You can just probably measure it by normal methods. And you also have patients that get a very deep remission and then slowly come back. And by doing MRD testing, we think we can learn how deep the response is. And then the big question is, and that's the next part of my talk, is how can that help actually patient care? How can it help to make any good decisions? So it's also good to mention that MRD is, a lot of things actually, a lot of good things were discovered in CLL, like the use of BTK inhibitors, the BCL2 inhibitors that are now used also in other types of lymphoma, and in AML, all started in CLL. But we cannot claim, the CLL doctors cannot claim that we discovered MRD. MRD actually came from other diseases, and a very important one is CML. And CML is a different disease. It has, the disease actually is only in one compartment, not in the lymph nodes and the blood and the marrow like CLL, but it all happens in the bone marrow. And the reason it happens is that you have this translocation from one chromosome, right? So BCR-ABL chromosome, that you have a swap of the parts of the chromosome, and that gives the disease, the BCR-ABL. And there are actually a lot of studies have been done, but actually now outside studies, it's very much already adapted that you give a patient a kinase inhibitor. You have a lot of different forms of that. And if you have a good remission with MRD negative disease, so you can't detect it anymore by the current techniques, the green one at the end, after 5 years, you can actually now stop treatment and you keep on follow those patients. And if the disease re-emerge again by MRD, a doctor knows by the guidelines, you re-initiate treatment. And we now know, after so many years, that 50% of patients you can actually stop if they reach this MRD negative time point at 5 years. And you have patients that stop and re-emerge, but then the question, of course, was, do you do harm by stopping and retreatment? And so far, it looks that you can very safely stop, take a break, and in some of those patients, you can stop forever, and in some, you just retreat and you don't get any problems. So we now already know that you can actually stop those patients. And now comes the problem that in CLL, we hoped, and I think we still hope, that we can use MRD as this very good surrogate endpoint to make a lot of decisions. And we might be able to do so, but it's good to realize that the difference is that in CLL, you don't have this one single driver mutations. We know from a lot of studies, it's a bit complicated slide, but there were a lot of studies done also in collaboration with the German CLL study group and KTVU in the United States, where there seems to be a lot of different genes involved in CLL. One are really driver mutations, and one actually occur during the disease. Some we maybe actually enforce ourselves because of the treatment we give. And that makes it already more difficult, maybe. And the other problem is this is a PET CT scan, so it's a CT scan where just before the treatment, patients get a very little bit of radio-labeled glucose. It's not a good test for CLL, but I just want to point out to you that CLL is not a single compartment disease. You can see it's in the marrow, like you see here in the spinal column, but you can also see that it's in the liver and in the spleen. and it is also, of course, in the blood. So therefore, already you can say that maybe a single compartment test could work, but it is challenging. That's what you have to realize. So then the question is where to measure MRD. And in the beginning, we did it all in the bone marrow. And of course, that is for doctors maybe convenient, but for the patient, maybe not so much. And we learned from the chemoimmunotherapy studies that there was really a big difference between blood and marrow. So you can be negative in the blood and still positive in the marrow. So the sensitivity of this test is low. But luckily with the newer agents, but we have to keep on testing with all the new agents that come, it looks very much that blood and marrow are much more comparable, and you can actually use blood, we think now, as a surrogate endpoint. So with all that having said, now we have a problem, or a challenge, maybe it's more positive to say, is now what? Now we think we have something, we know that we can measure it, we know that we can reliably measure one leukemia cell in 10,000 normal cells, that's called 10 to the minus 4. We can probably also go to 10 to the minus 5, and then what? What do we do with it? So I think these are the 4 things that we have very heavily discussed these last 2 days. You can either use it for the prognosis of a patient, so you give a certain drug, like 6 cycles of FCR, or 15 cycles of Ven-I, or 12 cycles of Ven-O, and you stop anyway, and the only thing it helps you or the patient is that you can tell something on the prognosis. You either give a lot of anxiety to the patient or you maybe comfort somebody, but that's it, which can still be very valuable, but maybe that's it. The other thing, but more interesting, is can you actually use this to guide treatment durations? Maybe some patients have a quicker response, so you can treat shorter, maybe less side effects, and some patients you maybe need to treat for prolonged periods of time. And the other, even more challenging part is, can we also use it to restart patients? Stop treatments, just follow MRDs, and before the patient becomes ill, before you get all kinds of complications, can you restart again? And maybe there are even other things to test there. So I'll quickly go to all those 4 of the current evidence. So I think the Germans, and I think Barbara is one of the key persons that actually made this happen, the way that they did their studies, you can actually not only learn a lot from one study, but with all their databases they built, you can actually learn a lot across all those studies. And one of the things that they very nicely showed, this is all chemoimmunotherapy-based, different regimens, is that indeed MRD is a very strong prognostic marker. So the different colors doesn't really matter so much, but that are the different treatment regimens that they tested in a phase 3 study. And what you see always is that independent of the treatment, if you are MRD negative, you do actually much better. So prognostic marker, I think everybody believes this after this data. Then the challenge came. The first trial that I was heavily involved with was the Murano study, a relapse refractory setting, first time that we tried targeted agent in a fixed duration. And this is the total progression-free survival, so you all know that it gives a much better progression-free survival in relapse setting than chemoimmunotherapy. And in the beginning, when we didn't know, of course, the long-term follow-up, all investigators were pretty disappointed, because if you look to this slide, what you can see here is that the patients, a lot of patients became indeed MRD negative, but there were only a few patients that got a complete response. And before these data, everybody always had the impression that you first have to get a complete response, meaning normal leukocytes, normal lymphocytes, normal blood platelets, but also no residual lymph nodes. That's important, and then afterwards maybe MRD is also important. And now we had a study that we had actually, let's say, less than 10% complete responses, but many patients were MRD negative, and we had no clue in the beginning, so what to expect now? Is it a good sign? Is it a bad sign? What do we do with it? And then in the follow-up studies, what we could show is, regardless of this lack of complete responses, patients with MRD negative disease, and there's a big discussion also, a lot of people saying you should not call it negative because there are always CLL cells still present, but it's undetectable, so you have to call it undetectable MRD. But those patients really had a much better prognosis, the green patients, than the red one. And this is not death, or to comfort you, but it is all about progression-free survival. And that's very similar also to what the German group later showed with venetoclax obinutuzumab, a very comparable regimen, but then 12 cycles and not rituximab, but obinutuzumab in first line. But it looked indeed that MRD, if you should make a hierarchy, MRD was more important to predict how the patient will do then this complete versus partial responses. So at least for this regimen, MRD is really something that helped a lot in telling your patient after the treatment what is probably to expect there. So next step is, can you actually use this to guide treatments? And I think you have all seen the slides. This is from the UK group, and the UK group took that actually to the test. So what happens if you get if you are MRD negative at a certain point? Can you then shorten the treatment or maybe prolong the treatment if you're not MRD negative? And they made a calculation where the expectation was that that the time that it took from start to MRD negativity, that time you should double for the treatment. So if you are MRD negative at 12 cycles, you need another 12 cycles to make sure that it's really gone, and then you stop. That was a very good hypothesis, and that's what they tried here. So that was the regimen. And first of all, the question was, okay, how quick can patient then stop? And what was interesting to see here is that overall, there was like 50% could stop their drugs in 27 months, meaning that they had MRD negative disease approximately at 13 months. But there was a very big difference in unmutated and mutated patients. In mutated patients, patient really had to go for very long times of therapy, almost finite therapy, I would say, with this drug to get to this MRD negative state. Some patients even never got there. While unmutated patients, the majority, you could actually stop earlier, still, I think, calling it time limited, 2 to 3 years treatments. And then what came out of it is with this regimen, with this MRD-guided treatment, and of course there was not an arm which did MRD-guided treatment. That would of course be actually very interesting and important. But you see, at least with this time-limited regimen, they did a very good job in very good progression-free survivals. So sorry to confuse you a bit more even, but it seems to be the case that with this same regimen, there are ibrutinib plus venetoclax, which we also tested in the GLOW study, which is a fixed duration schedule. What we found is very similar to what I earlier showed you by the German group from chemoimmunotherapy. Is these are patients, the upper part are patients that are MRD negative, MRD positive, and then the different types of lines are the different treatment options. It doesn't really matter here, but you see for unmutated patients, very clear MRD is a prognostic marker. But now you have the mutated patients where actually a minority got MRD negative. But those patients, it doesn't really matter. So there is not really a predictive marker or prognostic marker here. The last thing I want to show, and then I think my time is done already, is can you use it to restart? And this was done by a study that we developed together with the Nordic CLL study group. So the Hoven is the Dutch-Belgium group. The Nordic is the Scandinavian group. And together we did a trial where we gave venetoclax and ibrutinib for 15 cycles. Then patients that had MRD negative disease, we randomized for either continue ibrutinib like you would always do, or could we stop them and restart when MRD came back. And to make a long story short, what we could show actually is that for progressions, it doesn't really matter. If you stop and restart, and then your next line of treatment, there was no difference in the time that occurred. So it's feasible to stop and restart. But the most important thing, and maybe the important gain, is I think that if you keep patients on ibrutinib, and it very much goes to the former talks that you heard about infections, is that during ibrutinib, you actually are more vulnerable to getting infections while stopping, showing actually that there is, it's not only maybe more cost effective, maybe you get less side effects, but also you might prevent infections when you can MRD-guided stop treatment for at least a few months, maybe a few years even, and then restart. Did I skip in time for the time? Yeah, so in summary, actually, I think we learned a lot from MRD-guided treatments, and I think in almost all studies in the last 5 years, MRD has been an endpoint. On the other hand, in all different guidelines, the ESMO guidelines, the USA guidelines, all the national guidelines, MRD is still considered to be a test which you should only do in trials and not in real life because we don't know how to work with it. And I think it's very important, and we as doctors have to thank you very much, the communities, because the only thing we can come further is if you participate in trials to learn indeed how we can best use these measurements. Thank you.